Hello, everyone, and welcome to EuroNurse. We meet live every Saturday at 9 a.m. Central Daylight Time. My name is Vic Sinise, and I'm the host for today's show. If you're watching this on YouTube, you can learn more about us by visiting our website at euronurse.com. Our first half hour is going to be devoted to general urology questions, and in our second half hour, we're going to take a deeper dive into a subject. Today's subject is going to be telephone triage. To submit a question, simply click on the Q&A button and type your question. We have a great panel of experts today, so let's introduce today's panel, starting with Andrea Strong.
Hi, my name is Andrea Strong. I'm a nurse and a nurse practitioner. I work in Milwaukee, Wisconsin. I have 7 years of experience as an outpatient nurse doing telephone triage, and I worked as a urology nurse for most of the time for about 10 years, so I'm really excited to be here.
Great. And Lori?
Hi, I'm Lori Atkinson, and I've been in urology for 24 years now. So I have a lot of experience. Currently, I work at Northwestern at Delnor in Geneva, Illinois.
Great. So for our audience, our questions and answers box is available. You can go ahead and submit your questions. Take your time. I do have a question that came in from Katie Bortel. There is a on our website at euronurse.com, there is a button that says submit questions. So if you want to submit them ahead of time, that's not a bad idea either. So I did get this question: reprocessing scopes best practice. Does SUNA offer guidelines, or is there a course offered, or the medical rep instructions? And by the way, panelists, if you want to take the question, just let me know. All right, go ahead, Andrea, go ahead.
I have some to offer. I'm not involved with the reprocessing or the administration, process of that, but there is a white paper from SUNA on reprocessing of scopes. I'm not sure what year that was or what updates have been since then, but in my practice, I have seen the reprocessing done by a third-party company, where they come in and do it so that it's a standardized process and they're already up and running. So that's my experience. So that's what I have to offer on that question.
Yeah. So go ahead, Lori.
So our reprocess, we have a Medivator Advantage, and we recently had stored scopes, which we still do, but it was recalled. And so we had our sterilization at the hospital that actually reprocessed our scopes and sterilized them. We finally got scopes that we can do in the Medivator Advantage, but we're now looking at disposables, which we have on Monday. We have 15 scopes that we're going to try to do the disposables and see how it's like.
Yeah. Our practice actually switched over to disposables. You can't do everything with them, so they're limited. But I tell you what, I've been involved in urology for a long time, so I've saw the very first video scopes that came out, and they had a lot of issues where, as the light would hit the bladder wall, it would just kind of like blow the picture way out of focus. You couldn't see. These new scopes, I mean, for something you throw away, they are unbelievably clear. Really,
what
great
can't
picture.
you do with those?
They can't do procedures like bladder tumors. I think,
Okay.
I'm not sure if you can't put the fiber through it, or what the exact reason. The working channel may not be big enough for doing that. So I know they use other things. Since I don't get involved in that too much nowadays, it'd be a good one to get one of our nurses to be a panelist and kind of talk about those new scopes, because they are
Absolutely
really cool as far as visualization goes. And I'm going to bring an article up here. So I do know a little bit about reprocessing the flexible cystoscope, because let's see, where is it at? I actually was one of the authors on the original article. That. So much for the, I don't see. Oh, there it is. So there I am. So I did, that was 2013 that it came out. And there is even in the back of the article, I don't know if I can get to it real quick. It's a pretty long article. There was a in-office disinfection of flexible cystoscopes that we came up with. And that was a guideline that you can download and post in your reprocessing station. I think it was probably the best thing that we came out. It was one of the things I insisted that we do. So I thought that worked out really well. All right. Since there's no questions here, I'm going to switch back here to.
I had a question about, so I haven't been using those reusable scopes yet. What's the cost effectiveness on that?
Yeah, I asked the question myself, and the company rep had said that when you add in the cost of repair, replacement, and the reprocessing cost, that they come pretty close to break even. Now, again, I think that'd be a great subject to have for one of our presentations. So we're looking to try to get either a rep from the company or a nurse that's willing to speak up as a panelist and talk more about that.
Yeah, I'd be curious to know what the environmental impact is of those as well.
Yeah, well, that's for sure. I mean, medical waste is huge, and they're not, obviously not small. So they are a medical waste issue. So we're going to switch over while we're waiting for you guys to come up with some questions to something new. So here's my latest idea. Let's talk about a little bit of news, Euro news. So I'm going to make a shameless plug on how technology has changed urology nursing. If you're going to the New Orleans SUNA meeting, I'll be giving that presentation, and it's going to be from 1:30 to 2:30 on Saturday, October 1st. And then I thought what we try to do is people come up with questions that we talk about some articles that I read through just to see if there's any questions that come up on this. So does COVID-19 vaccine affect male fertility? And I will, this can be found in the AUA News, their journal. It was in the June edition, 2022. And the bottom line is, in conclusion, the COVID-19 vaccine was considered safe and does not affect sperm parameters and male fertility potential. Interestingly, though, they did find that COVID-19 infection appears to affect male fertility potential. Long-term studies are necessary to fully understand the impact. So I thought that was kind of an interesting thing. Any discussion or thoughts on that? Go ahead, Andrea.
I haven't had a chance to read the article or the research that was done, but I think it's a really important topic to bring up so that as healthcare providers, we know the correct information to give to our patients so that they can make an informed decision. And they often come to us, all medical staff, in the outpatient or inpatient setting, asking questions about the safety of vaccinations and treatments and other things. So it's important that we know what the current research shows so that we can help the patients advocate for themselves and make an informed decision on how they want to move forward.
Yeah, it's good. I know we were talking early on when we before we got the program going about the effect that the Roe versus Wade reversal had on the number of vasectomies. You guys want to talk a little bit about what you said as far as number of vasectomies in your practice increasing?
Sorry.
There you go.
So we've seen an increase, especially in young males that have actually come in for vasectomies, and I think they're worried about that whole scenario. So I'm just curious to see what everybody else is seeing, because we have an abundance of vasectomies and vasectomy consults that are coming in right now.
Yeah, that's good to know. I did get a question here. I'm at an outpatient urology practice that's having a number of issues with structure of its telephone triage. I'm not looking to get into details of our struggles, but can someone with great triage systems share how their system operates, an initial call to resolution of issues? Sorry, I know that I'm asking for a long explanation. I think it's a great question. I think what we'll do is tackle that when we get to after our discussion from Andrea on telephone triage, which if we have no other questions coming in, we'll just get into that sooner. But yeah, great questions, and feel free to submit your questions. I'm going to switch over here. So I have another news article that I was looking at. And it says, so secondary polycythemia in men receiving testosterone therapy increases the risk of major adverse cardiovascular events and venous thrombosis in the first year of therapy. So I thought this was kind of interesting. You know, there was a big push to treat men with low testosterone. And one of the things I thought most interesting is it was a database of 74 million people. And they kind of broke them into two cohorts, low testosterone who received and those who didn't. And, you know, we know polycythemia is a possible risk. And I'm just kind of curious what everybody in their practice is doing. And then, you know, in terms of this increased risk of a major cardiovascular event or a venous thrombosis, what your thoughts are regarding testosterone replacement therapy. So, Andrea, go ahead.
Yeah, so I don't treat low testosterone in my practice, but I have had some experience with it over the years. I have seen urologists or practitioners always get a baseline CBC, and then moving forward, serial CBCs, and then a cutoff at a certain level. You know, due to increased risk of cardiovascular events. And then in the beginning conversation of determining whether or not the patient wants to move forward with testosterone replacement, just making sort of a shared decision-making process where the patient's given all the information on the risks, the benefits, and then the patient can then make a decision on what they feel is best for them. So that's how I've seen it approached. But in my personal practice, I don't do testosterone treatment, so can't offer a whole lot on the current stuff.
Lori?
So I used to do a lot of testosterone, and what I've seen is that I think sometimes that we take patients that we give testosterone to that don't really need it. You know, they have low testosterone, but they don't have the symptoms. And so why treat a patient that has low testosterone but doesn't have any other issues? It's just that number that people look at. With the
Polycythemia.
Cythemia. So we obviously look at, you know, every 6 months, usually their testosterone, but also their hemoglobin and hematocrit. And if it's low and they're on testosterone and they're symptomatic, we do send them for blood dumping. So we send them to Life Source or, you know, some, you know, I don't even know how, it's been a while since I've done this because we don't do testosterone in our office anymore.
Yeah.
Because we send them to endocrinologists. But we did send them for blood dumping to make sure those levels are lower so that they don't end up with cardiovascular disease.
Yeah. We utilize that therapeutic phlebotomy also for that. So that's a good thing that I think what you mentioned is monitoring those, both the level of their testosterone and the level of their hemoglobin to make sure they're not, you know, ending up going into polycythemia. And I like the thought about, you know, are they really symptomatic? You know, because I work with a group of 5 urologists, and I can tell you I have 5 opinions on testosterone therapy. You know, there was some articles that came out early on when they started all going, highly into it, about increased cardiovascular disease for people with low testosterone, just naturally low testosterone. And, you know, of course, now we're saying that treating it may cause increased risk. So that pendulum, like typical in medicine, goes back and forth so much that you really don't know what to always think. And what you're preaching today, you're not preaching tomorrow. But I think it's the flexibility in watching and are we treating a symptom or just treating a number? I always think that, you know, of course,
you sometimes get those guys that come in that have low testosterone, but they're all buffed up, you know, they don't need it. My opinion.
And being a guy, you know, some of us have unrealistic expectations, you know. I've heard that, you know, the guy who comes in and says, yeah, you know, he says, I can't have sex every day like I used to. And I go, okay, that's a problem, you know. But their expectation is that they must have low testosterone. No, you know, you're now 70 years old and you probably do have it lowered because of age, but is that your real issue? So,
yeah, I think there is one step in this process that I think we miss often in healthcare, and that is talking to patients about weight loss, because a large amount of adipose tissue, especially around the waist area, will cause, a physiologic process that'll contribute to low testosterone. So I think our patients would benefit if we talk to them first, say, listen, if you can lose some weight, this is going to help this situation, rather than just jumping to testosterone replacement.
Yeah. I remember Michael Gray gave a talk on that, and he had said, we call it the apple belly syndrome or something. He says, if your patient looks like an apple, chances are they've got an estrogen factory growing there. That's that adipose tissue that's producing estrogens that compete with the testosterone. So since I don't see any questions coming in for general urology, I think we're going to switch over to our topic. So Andrea, I'm going to spotlight you, and you can go ahead and share your screen and give us a talk on telephone triage. For those of you that are watching, this went perfect during our practice session. So now you know it's live. There you go. You got it.
All right, we're back. All right. So as I said, my name is Andrea Strong. I'm a new nurse practitioner. I've been in practice for less than a year now. I absolutely love it. But I also worked as a registered nurse for a long time. I worked inpatient urology. I worked outpatient urology. I did a lot of telephone triage, which I'm super interested in this topic. So I'm excited to talk to you about that today. All right, so we'll do a brief presentation today. We're going to talk about patient safety, scenarios, legal issues. There'll be some time for questions at the end. I really hope that this is beneficial for all staff, nurses, medical assistants, managers, administration, everyone in between, because telephone triage is more than just the person talking to them on the phone. It requires like a whole system, a whole workflow to make sure that it's running smoothly to keep the patient safe. This is kind of geared towards outpatient, and I'm going to use the word ambulatory in this setting because that's the way that they want us to be using this terminology now, but ambulatory means outpatient. But our inpatient staff can also benefit from this, because I found that when I was working the urology floor on night shift, some of the patients didn't know who to call, and they would call the floor and ask for information, or we'd have to triage, calls at that time. So the biggest takeaway I want you to have from this presentation is that telephone triage shouldn't be an afterthought. It shouldn't be something that you're rushing to do between patients or between procedures. You need to have uninterrupted time in a private area to do telephone triage. I found that telephone triage was the most difficult thing that I did as an outpatient nurse. I also did a lot of different procedures. I was in the float pool. I did a lot of different things, but really this is practicing at the highest level of our license. So it really needs to be a priority in the practice. And I also recognize that not all clinics have registered nurses working, and sometimes our medical assistant or other staff are offering telephone triage as well. So I don't have any disclosures. I don't have any relevant financial relationships to disclose. So again, here's our outline. We'll do an intro, talk about patient safety and some legal issues. So kind of here's the history of it. Telehealth practice originally began when registered nurses were available to talk to patients over the phone. And this really helped build access to healthcare. The goal is to triage the patient to the appropriate level of care as quickly as possible. And then currently they use the word telehealth. So that's just an umbrella term that includes all of your virtual visits, your telephone calls, emails, faxes, MyChart messages, portal messages. And telehealth is considered a subspecialty within ambulatory care nursing. And again, ambulatory means outpatient. And the goal is really to get the patient to where they need to be as quickly as possible, whether that's the emergency room, urgent care, a same-day appointment in the clinic, or maybe it's reassurance as well. So as I said, telephone triage is arguably the highest level of care that you are providing as an ambulatory care professional. And as a registered nurse, this is really, you practicing at the highest level of your license. We did see an increase in telehealth during the pandemic, and I have found in my practice, a lot of patients still like to be seen in person, but some people now prefer the virtual route, especially in our rural areas, who takes them a long time to get to the office, or who have mobility issues. It's easier for them to be able to do a telehealth visit. And when I was, it's been a little bit since I was in my undergrad nursing school, but they really weren't offering a lot of telephone triage education at that time. Not sure if that's changed. Hopefully it has, but successful triaging requires qualified staff, a lot of training, and use of standardized protocols. And I really can't stress this enough to really make sure that this is a standard part of your onboarding program. And this is really going to help you advocate for your patients. So patient safety. So this is kind of back to the basics. Always identify yourself. I found that as soon as I told the patient, I'm a nurse here in the clinic, they were much more willing to share information, because sometimes the patient's not sure if they're talking to an unlicensed healthcare person. And in urology, sometimes the topics can be kind of embarrassing. So you want to identify yourself as a healthcare provider. Always ask the patient for their name and their birthday for a few reasons. One, that's maintaining HIPAA compliance, but you want to make sure that you have the correct chart open for that patient. I know in healthcare with our electronic medical records, we're rushing, we're moving fast, we have multiple charts open. So really make sure that you're in the correct chart. If the patient calls, and my experience has been with Epic electronic medical record systems. So there's something called, what's the word for it? They use like an in basket. So if the patient calls, the staff will put through a message, and then it goes into a queue that the nurses and the staff would work off of. But not everyone has access to this. I understand that. But if the patient calls for an emergency issue, you ideally want to try to reach the patient at least 3 times and document that information that you tried to reach them, whether it was by a MyChart message or a telephone call. And some things that I've learned the hard way, if you want the patient you determine that they need to call 911 from where they're at, make sure that you hang up with them and tell either the patient or someone who is physically with the patient to call 911, because if you try to call on their behalf, you're going to end up at the dispatch location that's in your area. The patient might live an hour or 2 hours away. That's a totally different dispatch location, and it can delay care because then you have to be transferred around to different dispatches until you get to the correct one that's nearest to the patient. Of course, if there's no other options, the patient can't call 911, then you should call on their behalf. But ideally, the patient or someone with the patient at that location should call 911. And then if you determine that the patient needs to go to an emergency room, be very specific that it should be the nearest emergency room. I've heard of scenarios where someone will say, listen, you need to go into the emergency room, and the patient assumes that it needs to be your specific emergency room. Well, they may need to take 2 buses and a train to get to your emergency room, or it takes 2 hours for them to drive to your emergency room. So be clear that it needs to be the nearest emergency room to the patient. For suicidal patients, this can be a really, really difficult phone call to make. Usually your employer will have some sort of protocols or standards on how to successfully triage a patient who calls with suicidal thoughts. In general, your goal is to keep that patient on the phone have another staff member call 911 to that patient's location. So those are sort of the general tips, but your employer should have a protocol on that. And at the end of your triage call, you always want to make sure that you're giving and reviewing the care advice. So if you offer reassurance, for example, let's say the patient maybe has a little bit of pink urine after a office cystoscopy, which is expected, you want to make sure that you tell them, okay, if this continues for, in the next 5 days, or if you develop fever, chills, pain with urination, frequency, urgency, please call our office back. And so the patient knows what the next steps are to take and what are the things that they need to watch out for that might be dangerous. If you're able to, and I know our clinics are super busy these days, but ideally you want to, if you tell a patient to go to the emergency room, you want to call them back in 15 to 20 minutes. Make sure that they have transportation, make sure that they're following through on your disposition. And then there are some telephone triage decision support tools that are available. Sometimes they're built into your electronic medical record. And I think oftentimes it's an extra product that needs to be purchased by your employer. But if they're not able to do that, or you don't have access to that, there are telephone triage books that are available. SUNA, the Society of Urologic Nurses and Associates, has a book. There's also different books. I ordered one on Amazon when I was triaging a lot of calls that can offer algorithms and guidelines. If you're ever on the phone with a patient and you're getting two different stories from the patient versus a family member, always go with the scenario that is the most concerning. And, really learning how to prioritize the complaints is really important as well. For example, if a patient calls and says, okay, I got a headache, I've got pink urine, and my temperature is 104. You don't really need to triage the headache or the pink urine. Go right for the temperature of 104, and your disposition should be based on the most severe complaint that the patient has. So for your safety, ideally you want to use a headset. If you're using a telephone and you're twisting your head to the side, that can cause an ergonomic related injury. So a headset is very much preferable, and it frees up both hands so that you can do your documentation as the patient is on the phone with you. Know your resources and use your resources. So maybe that's a publication, maybe that's your policies and procedures, or maybe that's a staff member who has more experience and that you can refer to for information. In the clinics, make sure that telephone triage is a standard process and that it's a big focus of the onboarding process for new hire staff. It's really important to advocate for uninterrupted telephone triage time. Telephone triage is a high-risk activity, and it's super important for patient safety. So you don't want to be doing telephone triage where you're getting constant interruptions, because that can threaten patient safety. So I just want to talk a little bit about social determinants of health. So these are the conditions that people are born with, they grow, live, work, and age. And in telephone triage, specifically access to transportation. So let's say you have a patient on the phone and you tell them, okay, I want you to go to the urgent care today to get care. Well, really make sure that that patient, do they have access? Do they have transportation to get to where they need to be? These are important things that we want to pay attention to. And then I just wanted to give some medication clinical pearls on some of the most common medications that are prescribed in urology. So fluoroquinolones, Cipro at one point was the #1 treatment for UTIs. Everybody got Cipro. now, that's really recommended as a last case scenario or a last case choice on treating UTIs, because there's 4 black box warnings on fluoroquinolones. There's an increased risk of tendinitis or tendon rupture, and this risk is increased in patients who are elderly or patients who are taking steroids. So I always make sure my patients know that if you develop any pain or swelling around your joints, in your calves, anything, stop the medicine immediately and go in for care. And this risk can continue even after finishing the medication. If the patient is very active in sports or training for marathons, really make sure to tell them to take it easy while they're on this medication to prevent any tendinitis or tendon rupture. Fluoroquinolones can also cause peripheral neuropathy. They can cause central nervous system side effects like seizures or psychiatric effects. And it's an exacerbation for myasthenia gravis. So a patient who has myasthenia gravis, which is a neuromuscular disorder that causes weakness in the skeletal muscles, you should never give them a fluoroquinolone. The Beers list. This is a list that was created by the American Geriatric Society with the ultimate goal of improving safe medication practices for geriatric patients. And couple pearls on that: nitrofurantoin or macrobid or macrodantin. You shouldn't use if the patient's creatinine clearance is less than 60 if it's a long-term medication. So we commonly give this medicine for patients with recurrent UTIs for a 6-month period. Just be very cautious and calculate that creatinine clearance before giving a patient nitrofurantoin for a 6-month period. Antimuscarinics for overactive bladder, so Detrol, Vesicare, and oxybutynin, all of those class of medicines are not great for patients over the age of 65. Don't use it if the patient's constipated, if they have delirium, dementia, or any cognitive impairment. I know this is a challenge in getting insurance coverage for these, but I always try to get prior authorizations for a safer medicine like a beta-3 agonist before giving anticholinergics or antimuscarinics to patients who are over the age of 65. Desmopressin, also known as DDAVP, is commonly used for nocturia, so patients getting up at night to go to the bathroom frequently. And it's a hormone that reduces the amount of urine that the patient's producing at night. And really be cautious on hyponatremia for these patients. So hyponatremia is a low salt level in the blood, and that can be very dangerous. So before the patient starts the medicine, check a baseline sodium level, and then I usually recheck it again about a week after the patient's been on the medication. Signs of low salt in the blood, also known as hyponatremia, would be nausea, vomiting, headache, fatigue, confusion, or muscle weakness. Flomax, also known as tamsulosin, is commonly used for males who have urinary retention or incomplete emptying. This can cause falls and orthostatic hypotension. So that's when the blood pressure drops quickly when the patient's going from like a position of lying down to standing up. So when I have a medication or when I start a patient on Flomax, I'll always tell the patient, listen, on the first time that you take this medication, it's most likely to make you feel lightheaded and dizzy. So take it at night before bed. And when you're getting up at night to urinate or when you're getting up in the morning, I want you to sit on the side of the bed for 3 to 5 minutes before you go standing up. If you go from a lying down position to a standing up position really fast, you could actually pass out. So I always, talk to my patients about how to prevent orthostatic hypotension when they're on an alpha blocker. And then for Viagra, if a patient ever calls and says that they're having difficulty with hearing, they need to stop that medication immediately and seek medical care. Also caution with Viagra and nitrates, caution with Viagra and Flomax. Patients should never take Flomax and Viagra at the same time because it can cause very low blood pressure. And they shouldn't be taking Viagra with their blood pressure pills with antihypertensives because, again, it can cause a drop in their blood pressure. So I'm going to run through a few scenarios here. So you've got a 20-year-old male. He calls stating, "My left testicle started hurting a few hours ago. It hurts so bad that I'm throwing up. This has happened before, but it usually doesn't last this long. He's not on any medications. He rates his pain as a 9 out of 10. His left testicle is hard and it's higher than the right testicle. He lives 2 hours away and his older brother is with him." So what's your disposition on this patient? This patient needs to go to the nearest emergency room immediately or call 911 if he doesn't have transportation, because what he's describing might be a testicular torsion. And this is when the testicle twists internally and the testicle can actually lose blood flow and need to be removed if it's not treated immediately. So this is really a medical emergency. This is called the twist score. So this is sort of a scoring system that can help you determine whether or not the patient might have a testicular torsion. So 2 points for testicular swelling, hard testes on palpation, nausea or vomiting, a high riding testicle, or an absent cremasteric reflex. So this is the reflex where if someone brushes the inside of the patient's thigh, you should see that the testicle elevates. If it doesn't, that's a little bit more concerning for testicular torsion. But again, if there's any question at all for testicular torsion or new onset testicular pain, I would recommend sending them to the emergency room, the nearest emergency room, immediately. Here's another scenario. There's a 50-year-old male calls stating, "My urine's pink. I think something's really wrong." He's on a statin, an aspirin, and an Ambien. He doesn't have any fever, chills, difficulty voiding, burning with urination. And then you take a look in his chart and realize that he had a cystoscopy done yesterday for microscopic blood in the urine. So what's your disposition? This patient's going to be offered reassurance because it's normal to have a little bit of blood in the urine after a procedure like a cystoscopy. So you can offer reassurance, but make sure that the patient understands that if this blood in the urine continues for multiple days, if it gets worse, if he's got large blood clots in his urine, difficulty urinating, any signs of a UTI, then he needs to call the office back. Here's another scenario. So a 40-year-old daughter calls. She's also the power of attorney for her mom. And her mother's an 88-year-old female. The daughter says her mother isn't acting right. She didn't sleep at all last night. She keeps saying that there's a small purple dog that's barking at her from the kitchen. They don't even own a dog. She fell down this morning. Her daughter was able to get her up, and now she's sleeping in the chair. Also, she said that the patient is incontinent of urine, which is new. They live 1 hour away and they have no access to transportation. What's your disposition for this patient? This is going to be to call 911 for several reasons. One, the patient showing signs of urosepsis, and she had a fall. There's always a concern if the patient hit their head that they could have some sort of bleeding in the brain. And another reason to call 911 is because they have no access to transportation. So they're going to need assistance immediately. So here's a few resources available to you. There's the telephone triage publication from the Society of Urologic Nurses and Associates, the American Academy of Ambulatory Care Nursing also has a telehealth nursing practice special interest group. They also have an entire nursing certification that you could get on telehealth alone. Your employer's policies and procedures, and then there's some telephone triage decision support tools Some of those are electronic and built into your system. You can also get a hard copy of books for that. So a few legal issues. Here are some high risk characteristics that place you and your practice at risk for litigation. Lack of uninterrupted time to triage. Inconsistent use of standards, protocols, or algorithms. Failure to conclude the proper disposition. Untimely or failure to return call. No telephone triage training for new hires. No use of a standardized documentation protocol. You should all be using the same standard. Commonly, I see an SBAR used for this. Also, delaying your documentation is high risk because it can cause poor quality. So when you're doing a telephone triage, you want to complete your documentation right then and there and not save it for the end of the day. You may not be able to recall important information from that call. Out of state calls. So triaging a patient who is out of state in a state that's not covered by the Nurse Licensure Compact Act puts you at a legal risk. So for example, if I'm triaging a patient on the phone in Illinois and the patient's on vacation in Florida, technically, I don't have a nursing license to practice in Florida, so I can't be telephone triaging that patient. For HIPAA, make sure that you're not sharing information with patients, friends, family who may be calling, trying to get information. Make sure that they are either the power of attorney or there is a signed consent on file for sharing medical information. Very cautious with faxes. That's actually a really big cause for HIPAA violations in the ambulatory setting. Just making sure every number is correct is important on faxes. Emails need to be encrypted. Sometimes patients will ask, oh, I've got my records, I'll just send it to you in an email. You really shouldn't be doing that because it can cause patient information to get into the wrong hands. They need to be using an encrypted portal. If they have MyChart, that's acceptable. And then performing telephone triage in a private area. This can be challenging, for a lot of clinics, but you don't really want to be challenged, or you don't want to be triaging phone calls in the lobby area where patients can and family members can overhear the scenario. So I want to leave this up for a moment so everyone can take a look at what state they're in. So this is the Nurse Licensure Compact. So if you are in a blue state, that is an NCL state, and you can triage any patient in any blue state. So I live in Wisconsin. I can telephone triage a patient in Missouri, in Florida, in Texas, all over the place. If you're in a state that is green in color, it's still pending legislation. If you're in a state that's a blue color, the Nursing License Compact has been enacted, but it's awaiting implementation. And then if you're in a purple state, that's partial implementation. So I'll leave this up for a moment so everyone can take a look at where they live and know whether or not your state is part of this compact. Okay, so that does it for me. Thank you so much. And we're going to open it up here. These are my references. Open it up for questions.
All right. Hey, that was really great. A lot of things kept going through my head as you're saying all this. And one of the things that hit me was taking some notes here about, when you call a patient up and they're not home, they leave a message. Hey, I'm having this problem. You call them. And I've been in this scenario many times. So I just try again, but I really haven't documented that I tried the first time. So usually it's after I've called a couple of times, I'll just write a quick note that tried calling patient twice or 3 times. Never was able to reach them. But I didn't think about it. Each time I probably should be documenting the time I did it and what I did. So my question though is what information are you comfortable leaving on it as a message for the patient? You can't reach them. So what do you do?
Yeah, that's a good question. So I think it would be, so if they call with something that you know is a medical emergency and you know that they need to go to the emergency room, I'll just leave them a message and say, I'm calling, from this office. We received the information. We recommend that you go to your nearest emergency room immediately. So at least you're leaving that on a voicemail. You're not saying what they called with or anything like that. You're just getting that information to them because that might be your only opportunity to get that information to the patient.
Yeah, that's good. May as well take this first one question that I have here because this came out during, I read it earlier, but I'm at an outpatient urology practice that's having a number of issues with the structure of his phone triage, not looking to get in details of our struggles, but can someone with great triage system share how their system operates from the initial resolution of the issue? Can you give us an answer to that one?
I can walk through what I've had in my prior experience. So I've worked in a practice that uses Epic, and the institution purchased an extra program. I believe it's called just Nurse Triage. So when the patient calls and they have a complaint, there's actually like a button that you push and it'll say hematuria or flank pain or whatever it is. And then it'll come up with a second series of questions that you need to ask. And these are yes or no questions. So any nausea, vomiting, fever, chills, and the questions are very specific to the complaint. And then at the end, it'll give you a disposition, and it really helps guide practice. It's not necessarily telling you how to practice, it's more of a guidance. So you can overrule that. You can say, okay, the system's telling me that they need to go to the urgent care, but I know they need to go to the ER. So you can increase the disposition or decrease it, because sometimes the system, the patient calls with flank pain, dysuria, hematuria, and they've got a ureteral stent in. So the system doesn't know that they have a stent in, but you know that they have a stent in and that they don't necessarily need to go to the emergency room. And then you can do your documentation right within that program. It's still on a telephone call. And then from there, most clinics would forward that to the attending so that they could review the information. If the disposition was to go to the nearest emergency room or call 911, we would call back in about 15 minutes to make sure that they actually did what they needed to do. So that's the system that we use. Now, when the patient calls, in a perfect world, you're going to have nurses who are sitting there waiting for telephone calls to come in, but I know that that's not possible for all clinics. So there was staff available to take a message, and they would just gather information, put it in a message, and then that would go into a queue where the staff would return the call. So that's, I hope I'm getting to enough information on what they're looking for on that, but it's very individualized depending on the practice.
Lori?
Yeah, that's very true. That it's individualized. So when patients call in, this is where we have difficulty too. They go to a call center. The call center has these keywords that they send, and they warm transfer these people. But it could be blood in the urine. It could be, I'm having difficulty urinating. It could be whatever. It may not be a total emergency depending on their history. So they're being warm transferred to our triage nurses that may not be available. And so we do have them take a message, and we try to get back to them as soon as we can. I had a scenario yesterday. So I was the only nurse in the office, but I had to run the floor. We're short MAs or whatever. I said, unless this person's dying, take a message. But they don't know where to differentiate, okay, they have a stent, like you said, Andrea, that if they have a stent, they have blood in the urine. Okay, That's not an emergency. They can't pee. Yes, that's an emergency. You know, so it's hard for our call center to differentiate. Even when they warm transfer them to our receptionists who are not clinical either. So they think, you know, gosh, it's an emergency. In my opinion, they can't pee, fever, severe pain. That's the only ones that I want transferred right now. But I just want other people's opinion on that.
Yeah, I agree. I think that's one of the big issues I think we struggle with is getting to the call. Sometimes I can remember, you know, my secretaries would take the calls and put back when we had charts, physical charts, you know, the good old days, and they'd be stacking up on my desk while I'm still seeing patients. And you try to look through them and see what questions on there were important looking, but sometimes you didn't get to it, and it could be something, you know, that should have been handled more timely. But a question that I have to that is, you know, our offices out there using automated systems, because I've had some doctor's offices, and as soon as you call, it says, if this is a medical emergency, hang up and dial 911. That's their big, I think, legal coverage. But, you know, and then if you need to talk to somebody, leave a message. Well, you're not talking to anybody human. So I think that, you know, the call center, at least if they may not be clinical, but you can kind of hear in somebody's voice panic or fear, or at least as another human being that you might be able to bargain with and say, hey, listen, this I really think is important. You need to get the doctor or the nurse to call me sooner than later. So what are your thoughts on that, Andrea?
Yeah, well, it sounds like just in general, there's a lot of challenges in healthcare with staffing and having the personnel in order to do this. Yeah, I think we do the best we can with the resources that we have. So sometimes they can't always get in to talk to a person in the clinic, but I think it's key that we take this information and these concerns and communicate that to leadership, to administration, because they may not be aware that this is a huge risk to patient safety and may not be thinking about these scenarios. So I think it is really important that we advocate for our patients on this. The American Academy of Ambulatory Care Nursing has a strong focus on telephone triage. So if you're in a practice and you're really looking for more information on this, that's a great resource to go to.
Yeah, good point. For our audience that's watching, please feel free to submit any questions that you have. If we haven't answered the questions that you wanted answered, go ahead and put it into the Q&A box. I do have a question that came in earlier from Katie Bortel in Plainfield. Said, SUNA offers guidelines, but any courses for RNs or MAs? And I don't know, is there a specific course on triage that anybody's aware of? Kind of look through the upcoming meeting. I don't see anything on that.
I don't think I've seen like an actual course in the past, but that would be a great idea.
And then a follow-up to that was, who in the practice does the calling? So maybe that's something that people in the audience could kind of chirp in on. You know, is it an MA? Is it an RN? Is it the doctor? Who do we?
Yeah, I think that's a great question, because that's a question that comes up in our office all the time, because, you know, in other practices, are MAs allowed to do refill requests? Can they do simple normal results? You know, I think the nurses need to do abnormal results, obviously urgent calls, things like that. But to try to differentiate MAs versus RNs, it's pretty widespread, and it's hard to determine. You know, I'm sure it's different in every practice.
Yeah. The thought, next time, maybe the next meeting or the next webinar, we can even do a poll to see what people that are attending are thinking, who does the calling, you know, kind of get a little feel for that from our audience. And then she also said, is there a question sheet for urology that can also be used for documentation? So you said there was that something in Epic that uses for documentation too. Is that questions and answers? Is that correct, Andrea?
Yeah, there is one. I mean, the institution has to purchase it, I think, separately. And I know Epic's sort of the Cadillac of systems, so not everyone's going to have access to that. But even if you just had your clinic, you just made your own protocol and said, we're going to use the SBAR. So situation, background, assessment, and recommendation. You know, there's other guidelines that you can use, but just making sure everyone's using a standardized process.
And the SUNA telephone triage manual, does that have some set questions to ask, or I haven't looked at that in a while?
It does.
Lori, you're shaking your head. Go
Oh,
ahead.
yeah, absolutely. Because I just gave it to my MA recently, and the new MA, because I said, even though it's a triage book, it gives the MAs definitions on hematuria or erectile dysfunction or kidney stones, and it gives them questions because they're rooming these people. So it's really educational for them to know what kind of questions to answer when they're rooming these patients, because the more information they give, the more information the doctor has. So they, you know, so they don't have to spend a lot of time researching everything this patient has. So
We did get a comment from the audience. All good questions. At our clinic, only RNs do all phone and in-person triage. I think that makes a lot of sense to me. We do have our meeting coming up in November for Chicago Metro at the Sheraton Lisle, November 19th. And one of our speakers is a malpractice lawyer. So I think there should be some good questions that we could get from him. And maybe I could talk him into being a panelist one of these days too, to get on and talk to answer our questions in a webinar. Hello, just an FYI, in Epic, there's a way to document outgoing calls. I've used it many times. If I can't get a hold of the patient, I fill this outgoing call section. It's very detailed. So I think Epic is really the winner, but as you said, not everybody has it.
Yeah.
I use Epic. The only difference is that all Epics are different in each. Yeah. So, I mean, I came from another practice that came to this practice that every Epic is, it's similar, but it's completely different. So to find these areas that can use, it's not together. It doesn't pertain to every Epic.
It sounds like you need a special module that you were saying, right, Andrea? To Epic, it's not the standard.
Yeah, I believe it's like an add-on product that you can add called telephone triage. I believe, I don't know for sure, but maybe we need someone from Epic or.
Yeah. Well, this is reaching the end of our hour. It's been a great discussion. I really appreciated all the information that you guys provided. Thanks, audience, for coming in again and supporting us. This is hopefully as helpful for you as it is for us. And I just want to encourage you. There is a survey that'll come out. Fill that out. Let us know what you like, what you don't like, what you want to see. We do look at those things later on. And we're going to invite you to the after party. It's been, after we close this, we're going to open up a Zoom meeting. If you go to euronurse.com and click that big red button that you see there that says after party, it'll instantly transport you to the cool spot. So we hope to see a few of you over in the after party. But thanks again for your coming to the meeting, and we look forward to seeing you next week. That's it. Thank you.
Thanks.